Hi, Dr. Goldstein.
Hi, Daryl. How are you?
I'm good. Hope you are too. I love your consulting room slash home, I guess, or so. But I'm grateful for you taking time out of your day to speak to us during our conference. Can you tell our audience what you do and where you do it?
Sure, yeah. So I founded a practice called Bespoke Surgical. It's out of New York on 12th Street about 10 years ago. And it's all about providing a destigmatizing place for people to understand sexual function, specifically anal sex, and have a place to seek medical and aesthetic practices to make sure that people are getting what they want sexually. So a lot of people have issues where they're tearing, they can't engage anally, they want to take bigger, they aesthetically have issues. And how do we support that on a surgical and medical approach, as well as a holistic approach?
So how do you support that? I mean, when a person walks into your office, do they know that you're, and indeed you are out as a gay man and
Yep.
as a gay doctor, as a doctor who is a gay man? Do they know that in advance, or is there a conversation about that?
Yeah, most people, because we're basically the only ones that truly provide this type of practice in the world, a lot through popular press and social, people really are knowing what they're coming for. They're searching on the internet and looking for all these different types of topics. And we're really trying to push the narrative to talk about all of these things just because it's been hidden for so long and people don't get educated. That's completely limited throughout. And realistically, if you look at the trajectory of gay men, specifically with HIV and AIDS and the years of that, we're basically the first ever out living gay population. And so for me, it was so important to start a practice that was really going to highlight that and honor that and really destigmatize all the issues that nobody was educating on, that people don't want to talk about. And how do we throw it out there for everybody in a way that I think is socially where it should be, and pushing the narrative and pushing kind of the gay world as I see it, that I think is super important for everybody.
So actually, treatment begins the moment they walk through the door. I mean, there's a sense of relaxation, removal of tension, expectations that you're understood without having to describe yourself in details and such. Is that fair to say?
Totally. Yeah, even from just the way that we approach the office and, getting you in, and the practice itself and the offices, it's just more of a collaborative approach. And with that, the taboo is completely removed. So at least we could focus on what we need to. And me being gay and out and talking about all these issues is so much more of a comforting factor for people, that they're able to now say, all right, these are the true issues at hand, and how do we really tackle them?
So when a heterosexual man walks through your front door and sits in your waiting room or steps to the receptionist, what are they seeing or feeling or understanding that's different from the offices that they would ordinarily go to?
I think similar to that effect, I mean, we're not specifically only gay men, we're all men, all women, post-pregnancy. I think the key component, and it doesn't necessarily need to be, I take it up the ass and I'm engaging anally, specifically on the hetero side, though many times now anal play is such a vogue thing. That every human, wherever, starts to really reap those benefits, especially people that have prostates. When you start to see the positive effects for orgasm and really the over encompassing components of that, when you start engaging in anal or prostate play, it just enhances that. With that being said, I think the heteronormative approach, by them coming to a gay man, they know that we're seeing the volume. Obviously, if we're able to get people to engage and defecate and engage the way they want sexually, they're feeling super comfortable with that. And also, a lot of the anal play stuff really is such that vogue thing that people want to know about it, and we're able to kind of really provide that in a very discreet but open way.
Yeah, my urologist was telling me 2 or 3 weeks ago that he had a couple in their early 20s walk into her, make an appointment, sit down. Why are you here? Well, we want to learn about pegging. We've heard about it, and we thought before we try, let's talk to somebody who knows how to do that. And it sort of speaks to the idea that you should be treated by people who know what they're doing, which is almost like a beyond common sense kind of sentence. But, if you're dealing with urologists who treat cancer and, just know how to cut it out, or radiation oncologists who will burn it out or so, you still want a quality of life, and you want a doctor who understands quality of life. Why do you think there aren't more doctors with practices like yours?
I think that obviously I'd love more and more physicians to start taking this on. Specifically, it doesn't need to be the urologist, the radiation oncologist. This is not very complicated stuff, but their mindset is, are you shitting correctly? It never goes into the sexual side. It doesn't register. So you can't really blame, even though I would love for them to kind of take the onus to say, okay, I'm seeing more people interested in pegging. I'm seeking a lot of men that identify as gay and are bottoming. What can I do to educate myself to figure out the appropriate radiation dosing, or figure out how do we post prostatectomy and all of these issues? How do we tend to the anal issues? Or a lot of people have erectile dysfunction post prostatectomy, and now they need to reinvent their sexual world anally. How do we support that? And how do you talk about it? I did a very early study in my career that showed that 92% of even gay physicians will not talk about sex, specifically anal sex. And so you raise a really great point, which is, why are we as physicians still limited in talking about things that we all should be so well versed on, and understanding the component and implications to now change our practice to suit that? It should be standard of care. And I'm hoping that what we're doing is pushing it out there, that narrative. I'm hoping that we're working with schools and educators to try to figure out, can we start implementing this early on in people's residencies and medical schools, to really start to see if we can kind of move the needle into a great space.
So let's get into nitty-gritty, helpful hints, and everything our audience actually wants to hear, which is like, what can I do to make myself feel happier and enjoy my life in a better way? So you have prostate cancer patients walking through your door. Not all of your patients are prostate cancer patients, but some of them, and I
Totally.
imagine like, what let's go through like 3 or 4 scenarios of different patients that walk through the door after they've either had radiation or surgery. You pick
Yeah,
one. Yeah.
totally. So let's talk about radiation. The problem with radiation is, whether it's targeted, whether it's through beads, whatever the approach is, you have to understand the mechanics of anal sex. Anal sex feels so good because people are banging and hitting the prostate. With that being said, when you start using radiation in that capacity, it is not only treating, even though we would love for it to be completely local, it is treating 360 degrees around. So the soft tissue, the muscle, the anal region, it becomes part of that radiation field. And there's lots of things that can happen with that. And it's the same thing with anal cancer with radiation. You start to see changes in the tissue surrounding, irritation, friability, all of these things that now you can imagine, whether you're using toys, whether you're engaging anally, whatever that is, it is now going to actually hit the area of irritation and cause potential problems, meaning pain, bleeding, limitations, just because it doesn't feel the way that it should. And a lot of that can be transient when people are going through the process. A lot of people don't feel very sexy regardless when they're initially getting treated, but understanding those implications. So I usually break sex into, well, what happens before sex? What happens during sex? and what's the after sex. And I think for prostate cancer patients, there needs to be a bucket even before all of that to make sure that people are educated in talking about anal sex before you start treatment. What are the treatments that they are suggesting? What are those limitations as it relates to how you want to engage? Obviously, erection issues, whether you're going to actually ejaculate and come and orgasm, and then bring the anal issues into those discussions. If you are getting, complete blank stares, then you really need to reevaluate and either come to our office and chat about these issues or conference us in with these physicians so that we're all starting to talk about. Because the thing that I see is anal scarring, anal stricturing or restriction, irritation as it is, post-treatment. All of those things start to limit people as it relates to their anal engagements. And we had spoken a little bit before about, again, the erectile issues that some people see, especially post-prostatectomy. Can you get hard? Can you get off? Those types of things. Now you start to say, okay, if I'm bringing anal into it, how do I start to really make sure that people are doing the right things? Now, post-radiation, we know that even if they do radiation external beam or seeds or whatnot, it lasts for quite a while post-treatment, right? People talk about weeks to months, and then finally it starts to wane. Well, during that time, I would want to start using anal toys and dilators and trying to see if the scarring is going to happen. Can we, one, do a really great history and physical exam to look inside and see the extent of scarring, because there's so much deviation and variation from that. Two is, can we shape scar? Now, in my surgical practice, I do a lot of that, meaning I do my surgery, I'm creating scar no matter what, but I use Botox a lot to relax the muscle and the skin. I start using toys 6 to 8 weeks post-surgery so that if a scar is going to develop, scar itself is very weak and very restrictive. How do we now, understanding anal sex, we need it to be strong and we need it to be elastic. So by training it and working with it, we start to shape. And you had conversations with Steve Lavender, who's a dear friend and a physical therapist in our office. And we do a lot of work with manometry, pre-testing, during treatment testing, post-evaluation, and start kind of really seeing if we can manipulate the normal post-operative course for any type of prostate procedure and really making it as beneficial for us from a sexual perspective. I know it's a lot of talk, but I hope you got some stuff out of that.
No, that was good. But I guess the main question is it possible? I mean, what's the success rate that you would have from a course of treatment with someone?
Totally possible. It depends on the extent of what they're doing, and it depends on when people are coming into the office. Nowadays, because radiation and treatments have gotten very specific with, even if you're doing prostatectomies, robotic, and really isolated, all of those specifics have really improved sexual function throughout, right? We know that over time, people are getting better and better responses from the treatment. Get rid of the prostate cancer, albeit keeping the sexual function. With that being said, the key component is to start bringing sexual discussions into the mix before, during, and after. And yes, I mean, I think the saving grace for me is that the anal region heals really well. It is significantly less as it relates to scarring if you're doing all the right things. And it starts to really allow people a second coming from a sexual perspective, because a lot of erectile issues are still present, that now we could start to say, okay, how do we start using the anal cavity in a positive light to let you be super representative in the gay community, continue your sexual world, feel confident. So yeah, totally. I see a ton of success with that, but it's work and you have to put in the work. And the key is to know beforehand, what can we do to prevent issues so that it minimizes what we need to do after the treatment.
So for men who have had a radical prostatectomy, they no longer have a prostate. No nerves adjacent to the prostate remain. I mean, to the extent that
Some,
they've some,
clearly,
yeah,
right,
yeah.
yeah.
But basically, there's nothing really to play with. What can the rectum, can the anal, what is there left that could be amplified to restore
Lots.
pleasure? Go ahead.
Lots. So,
Yeah.
so when you think of, especially with women, with a ton are engaging anally, and why do they, feel pleasure? You have pelvic nerves, you have rectal and anal nerves that are positively stimulated and appropriately to that degree. So I think that when I'm talking about the prostate really creating a really, excuse me, amazing orgasm, that's because obviously the prostate is bulging with fluid, and finally that's part of the ejaculatory component. When that is gone, the sensations of the nerve endings pick it up. And so a lot of people still get significant amount of pleasure. And we also need to talk that having someone behind you and seeing their pleasure feeds that endorphin approach, where you really start to see your relevancy in the process provide positivity. So I don't want people to think that, oh, just because their prostate is away, that you can't gain anal pleasure. No way. I mean, I see tons of people gaining complete. Even think about just rimming and external play, how stimulatory that is. But I do think that what we need to do is, depending upon each treatment that is being sought, it's now breaking that down. If anal sex is important, to now start to say, well, can I engage anally after that treatment? When can I start to do that? Are my pleasures going to be the same, diminished? And what are those differences in all those different treatments? And it's not going to be easy because most physicians won't talk about it.
Yeah. What do you think should be required by physicians to talk, like the top 2 or 3 things they must, in your opinion, and probably in mine as well, actually speak to the patient about?
Well, first off, I think that if they're not talking about sexual function and incorporating anal and asking you about your lifestyle, I personally don't feel comfortable with that. Now, you can look at the best prostate surgeon, the best of this, and say, well, I'm going for the technique. Well, yes, you need to understand that if they're doing 1 million a week and you're like, hey, I want that person, I'm okay with that. But just really starting to you have to take ownership of yourself. So when you're in those conversations, you need to say confidently, hey, I'm a gay male, I engage anally, and really throw it out there and start to see if you feel comfortable with their responses. So that I think is on one side. The other side just comes to really, from my perspective, is when you're driving that conversation is really to really understand the implications as it relates to every decision that you're making. And that is doing a lot of research, speaking to people, really staying on top of the current literature as it supports how do we start bringing sex into that world. I think, again, the key component for me is early use, early dilation, early understanding of seeing where things are, seeing someone like me during the process so that I could see the extent of radiation, extent of trauma to the area, document it, and then start to see the improvement as it relates to that, to start setting the stage for success. It's not just wait until the completion of treatment. It needs to be during that we're really reevaluating all of these issues.
Do you think it's safe for patients to independently, without doctor supervision, do anal dilation, particularly during radiation therapy?
I think it's no different than anybody else that's starting anal dilation. The key component is, one, to understand protocols. Two is to understand which substances of silicone or glass. I'm a big glass component just because you could use whatever lube that you want. I think silicone lubes are the best for anal. Scarring, water-based lubes don't pick up on the scar tissue very well, whereas silicone does. So I'm a huge proponent of silicone, specifically post-radiation. Also, lube shooters are amazing. They're actually syringes that shoot the lube up into the anal canal. Anybody that has scarring post-radiation, should be using that. So now you have silicone lube, that's the best. You have an appropriate delivery of that, and you start sequentially with small to medium to large toys, understanding that for the first 2 to 3 weeks, you're just staying with the small toy. You may be like, Evan, I can take more. I feel like I can take more. I don't want you to yet. Why? Because it takes time for us to reshape that scar. And you want to gradually start to strengthen and toughen it, all the while making sure that you're not bleeding, that you're not causing irritation, that you're not limiting those components. And so, yes, if you're doing self-dilation, I'm all for that, but know what we're talking about now, understand the protocols, use the right substances and the products to support that, and then slowly start the process. If someone comes to my office and says, I want to engage anally, it's about a 6 to 8 week process of using toys 2 to 3 times a week, just like going to the gym, and slowly working the skin, the muscle, and now the new scar post-treatment that has developed.
Yeah, and hygiene as well. Good hygiene. You don't want to introduce bacteria.
Yeah, but just to know that one of the things I think is it was super important, we talk a lot about, is that a lot of people are over douching and or douching with toy work.
Mm-hmm.
I don't recommend douching with toy work just because hopefully you're just, especially in the beginning, you should be doing this just on your own in the shower. By douching, you start to change the microbiome. I started a company called Future Method, which is all about products to support our community. And the products itself are douching substances that are not toxic. They don't change the microbiome. They support, instead of water drying you out, it kind of creates a coating and a lining. We also have a probiotic that's specific for anal sex, meaning that we know that lubes and douching and toys and sex change the microbiome. So how do we use pre and probiotics, which is now called a symbiotic, to start replacing the microbiome locally in that place? So these are all those things that I think of. How do you use dilation? How do you use better douching techniques and products? How do you put fiber and probiotics into your space using lube shooters? All of these things to locally maximize the benefits that we're trying to seek, all the while minimizing any potential trauma post-specific prostate treatment.
If a man's lucky enough to have a partner or a husband, what role do they have in all this?
Yeah, I mean, I think that one is a lot of them can obviously be supportive just emotionally and supportive mentally as it relates to that. I think also talking about, if you were a bottom before treatment, what's it going to be like after treatment? During treatment, do you need to open up relationships and look at your own relationship to make sure that your partner is happy and satisfied during the course of that? There's a lot of all of that just kind of that should be discussed, because we're a unit, and making sure that there's communication and the approach is to that family dynamic. As it relates to sex itself, I think that, look, a lot of these guys want to just get behind you and go crazy. That can't happen until it's proven that you're able to get into a good place sexually as a partner. So I usually tell people using the toys is really great. One, before, without your partner, then maybe start bringing the toy work with your partner so that they could be part of the process. Also, they could start to see the different angles that you feel really good at. Things like doggy style behind is actually really good post prostate. Why? Because someone's penis that is erect is actually angling away from the prostate. So just by understanding the pelvic floor and the right positioning, it starts to set the stage for partnerships to be successful. So I usually tell people I love partners being involved. One, because it's open lines of communication. Two, they're getting an appropriate education. Three is you're able to start really working the relationship. And then when you are starting to engage where that person is the deliverant, the reality is that you are now setting the stage for success for that to happen.
Urinary incontinence is a big concern as well, and climacteria. And I mean, do you in your practice get involved in helping men with that?
Yeah, so I think a lot of that is Steve with physical therapy. We also work with a chair that's called an Emsella device that works for really strengthening the entire pelvic floor. Now, I use it anally for people that come to me where they've been having lots of anal sex or fisting, bigger toys. And what happens is their muscles become quite elastic, where now we're trying to strengthen that and pull that in. And it's very similar to post nerve injury or post prostatectomy, where you're getting these issues. Or again, how do you use the rest of the pelvic floor to compensate and pull in to try to aid all those issues that you mentioned? So I do see a lot of it. And it is really important to, one, see a physical therapist and work with them. But two is, how do we use the anal musculature and everything we know about anal sex to help not only that, but help the entire pelvic floor for some of your other issues?
Yeah, and erectile dysfunction, particularly after surgery. What advice or helpful hints do you have around that?
It's a tough one. Obviously, it's a lot of it is a waiting game, just because a lot of that nerve endings do come back. I think that the key component that I see is you really want to study the person that's doing that procedure, to truly, truly study their results and really hold that, because a lot of times I'm a huge proponent of, listen, the best guitarists in the world play the same song all the time. So when I tell someone, how do you choose somebody? They should be doing a ridiculous amount of surgery every week on the same issue that you have. And with that, you're going to find that you have the best team, you have the best nurses, you have the best surgeons, you have the best components to that. And realistically, sexual function follows suit to that, because you'll start to see that those people that are the busiest in the busiest centers are having the best results.
Yeah, and it keeps falling back to this insanely unfortunate idea that most doctors don't ask. Uh, there was a friend of mine, a radiation oncologist, put on his Twitter account question, like a poll, do you ask your patients about sexual orientation, or however he phrased. 77% said no, they never ask. It wasn't even like I do or I don't. It was very clear. And the replies were, I don't think it's relevant. In Malecare's clinical trial in collaboration with University of Minnesota, we found nearly 80% don't ask. This is extraordinarily insane, and it's not going to change in medical school. It's not going to change in our generation, or, the generation of our children. What, what can we do to motivate patients to speak up or walk out the door of a doctor that they just don't feel comfortable with?
I think you're doing great things, just like what we're trying to do, right? Which is to push this narrative and empower people to start not looking at that physician as this God complex, and start to say, hey, these are real issues. I think that what we could do is try to be collaborative, and maybe we come up, me and you and our team come up with question and answer components that need to be hit, that provide specifically gay patients and clients with the narratives and the tools to really ask the right questions as it relates to that. It should be standard. It should be standard of care, just like a pathologist has to go through X, Y, and Z for prostate staging. This sexual questionnaire should be standard for every physician to ask, so that they're able to now start to tailor treatment to that. And we have to hold people accountable. And if they're not going to even, broach the subject, then I honestly think that you have to really question whether or not that person is going to be the best person for you. And there's not going to be a right answer, but I at Bespoke and Future Method and all of what we're doing is speaking to this to as much popular press as possible, because the physicians are, pardon my French, physicians are fucked. They don't want to listen. They're not going to change. I've tried so many times. That's not going to work like that. It has to empower the people to really demand a specific change, specifically in our gay community.
Yeah, Yeah, I mean, this idea, within my nonprofit world and my counterparts that, whether it's an LGBT focused organization or just a cancer thing or a prostate cancer thing, it's all for them. It's all about enhancing cultural literacy, putting together 3-hour CEU credit worthy courses to teach people what the Q in LGBTQ stands for. But, and that's sweet and kind and nothing wrong with that, but it ain't changing a practice. It's helping to monetize and bring in revenue to the nonprofit. And that's the beginning, middle, and end of most of those efforts. But doctors are just not going to change because doctors are people like you and I and whatever. And you just grow up and have your personality. And most of the time it's innocent, and no one's waking up and saying I'm going to be a homophobe today, But
Right, right.
it amounts to the same thing. We tell our patients you're the pilot. Or you're the cancer co-pilot is really the phrasing we use. And you've got your checklist before you leave the airport. Before you fly away, you check, the flaps, the oil, whatever pilots actually do. You know, you have to go into the consult with your own either mental checklist or written down in front of you or on your phone and say, these are the questions I'm asking my doctor, and I'm not leaving this chair until those answers become understandable to me and acceptable to me. Um, it's pure agony for patients in the community who go in expecting care and are getting at best superficial attention, aside from the general complaints about 5 or 10 minute consults, to not really have a doctor that's interested in you, you know.
Yeah, I agree 100%. But I do see that now, specifically in the generation that's coming through, that there's a lot more out physicians. There's a lot more specifically gay urologists and proctologists, and a lot of this kind of world where I'm hoping in due time that this starts to become a true focus. And we're working to build a center specifically for that, urological, gynecological, and proctological, from all the gamuts of really looking at it as a sexual wellness center, to really start to say, okay, how do we now support the patients and also the physicians, so that even if a physician doesn't know, this is the one thing that just pisses me off. You could be the best surgeon in the world, and I am totally fine with you answering, I don't know, but I know for you to go. And so, meaning if that surgeon says, look, my job is to get out the prostate and cure you, and I do a bazillion of these, and you feel comfortable with that. On the sexual side, I have this group that is really the best, and I want you to see them. That's fine. That is fine. That just calls attention to that you're thinking about it. You've handled this before. You understand that there are implications and ramifications. You may not necessarily know how to treat those, but you know the right people to make that referral. So that is where I say, you don't have to be the person to know all the answers, but you do need to say, one, I don't do that. And two, but these are the people that work with me to accomplish that. And then I'm totally fine with that.
Brilliant. Let's leave it at that, because it's truly the best advice is to see a doctor who knows when to say I don't know.
Exactly,
Yeah.
exactly. So that just hits both the chords.
Dr. Goldstein, thank you so much for being part of our conference. Welcome to Mailcare's faculty, and I'm grateful for your time as well as our virtual audience behind me.
Awesome. Thank you so much. I appreciate it.
Thank you.